Hi, my name is Bernadette McGovern. I've been working here in Tallaght Hospital since more or less when it opened in 1999, actually, just shortly after it opened. I am the colorectal nurse manager for the services here, and my background would be also colorectal. I worked in the Mater Hospital under Mr. Ronan Connell, where I would have worked as the first stomach care nurse for the hospital there in the Mater for 5 years. I came to Tallaght in 1999 and I have seen obviously great changes in the services, lots of different consultants coming and going, and I suppose over the last couple of years I've looked at different issues within the services which I think are seriously lacking in some organisation. And I was looking at the waiting lists specifically 2 years ago at all the people on routine waiting lists for the surgical teams. So within that group I noticed a lot of, I suppose, young patients that were maybe coming in with basic complaints like painful piles or itchy tail ends or whatever. So very much the bread and butter benign stuff of the service, which seemed to me to be quite ignored really, because it wasn't that, it wasn't glossy, it wasn't a tumour, it wasn't anything really that anyone would worry about. However, I suppose where I looked at this was that if I were going to a dentist with a sore tooth, I'd like to see that it would be done and dealt with quickly. And then I thought for some of these people that were directly referred by GPs with painful piles, that they literally went on a pile of lists to be seen by somebody within the departments of surgery. And we know this is not alone where they're not being seen, but they're also being triaged to all sorts of different consultants. So I knew there were a lot of issues to be addressed. I suppose the numbers were there. There was great debate as to whether we needed to really address it, but I did feel strongly that it wasn't right to have these young people sitting around with basic benign conditions that weren't being looked at in over 4 or 5 years. And in fact, when we went back to look at the lists of the long waiters, the only reason why we did it was because obviously there was pressure from the HSE to try and clear our lists. So a lot of these people had gone to other departments or other hospitals, shall I say, for an opinion. So I decided, along with Professor Neary, to maybe look at some of those patients that might be suitable for a procedure clinic. And in fact, some of the letters from GPs were very clearly stating that the patient had a painful pile or a bit of rectal bleeding, bright red rectal bleeding with no family history. So it was very clearly indicated on GP letters that it was just a case that they needed to have an evaluation of it, or at least a proctoscopy to see if there was a pile there. So we identified obviously a group within that list that we could potentially see at a procedure clinic. And we decided to set aside one clinic maybe in every 4 to 6 weeks to try and clear some of that waiting list back. It was surely literally to clear a waiting list that we were pushed to do something like this. So we pulled out all those patients that we regarded as suitable candidates for this clinic. And that would have included people as well with maybe itchy tail ends and thrombosed piles. It was very, very much the benign stuff. And we looked through the list and we started the clinic, and already we had an established clinic. So we had a procedure room, we didn't need to get anything extra. We had the equipment like the proctoscopes, we had the nurses, we had the consultant on his team there. So there was no need to actually look at developing any more staff at the time. So we started to really attack the waiting list and get people in. Now I suppose in the first few clinics that we had, most of them, we had quite a few DNAs because they had been lost to the service. They either had decided it was no longer a problem or they went elsewhere, and that was understandable. We found as we got into the lists that were getting nearer to the dates that we, to the shorter waiting lists, we found that those patients were coming, and it was very simple that we were explaining to them that we were going to just examine their tail ends and establish if they needed to have intervention, be it injection or banding. Then I would give them the advice basically on management and dietary aspects and keeping the bowels moved. All that simple stuff, simple bread and butter everyday stuff. But the beauty of it was that you felt we were actually seeing these people, and then we were actually deciding within that group if there was any of them needed to be triaged to an endoscopy service, which we know is already an overstretched service. And we were able to identify ones that definitely needed to be scoped, so we through either family history or concerns about other symptoms. So even in that alone, it was going to be very effective. And for those that were waiting on lists from the gastroenterology department, waiting to come to be to be seen just to have treatment like, you know, injections, we were able to take those people a lot quicker from the endoscopy services. And likewise, we got 2 or 3 patients really within the first few trials of the procedure clinic. We got patients coming from the casualty department who had come in with thrombosed piles, and we were able to deal with those very efficiently. So I feel overall, I suppose, it wasn't a massive big change. It was just a case of actually identifying people that should be seen within a respectable time, even though it's only benign. And as I said, I compared it to the dentist. Why shouldn't a patient be seen if they have these basic little frustrating problems? So that's really where I came from it, and we spoke about it, and Professor Neary agreed to it.